Good evening, everyone. My name is Gabriele Colasurdo. I'm the Manager of Education and Patient Services at Myeloma Canada. I'd like to welcome everyone here tonight for an educational webinar on the latest myeloma research updates from EHA 2019. Our presenter tonight will be Dr. Rami Kotbi, who is a hematologist and medical oncologist at Cancer Care Manitoba in Winnipeg. Before we get to Dr. Kott's presentation, I'll just a few notes to start off. So all of our webinars are recorded and they're available on our YouTube channel, as well as from our website. Now, from YouTube, www.youtube.com, if you search in the search bar, you write Myeloma Canada, one of the first links that you'll see is Myeloma Canada. And if you click there, you'll be able to see all the videos that we've uploaded. All the videos that we've uploaded. If you click on subscribe right over here, you'll be able to subscribe to our channel. That way, whenever we add a new video, you'll get a notification on YouTube. The other way to get to our channel on YouTube is through our website. If you click on resources and then on Myeloma Canada educational videos, it'll take you to the YouTube channel. Next, before we go to the presentation, I just want to let everyone know how to ask questions. So at the end of the webinar, you'll be able to send me your questions. You could actually send your questions during the webinar, and I will read them to Dr. Kott at the end of the presentation. To do that, on your GoToWebinar panel, you'll see a little tab that says questions. If you click on the little arrow to open it, you'll have a little box here where you can type in your question. And then once it's typed in, you press send. I'll receive it. I'll read it to Dr. Kott for him to answer it. So without further ado, I'd like to introduce Dr. Rami Kotbi, who will present tonight.
Hello, everybody, and thanks for signing in. Thanks for joining us for this session. So the talk today is about the update on the management of multiple myeloma, according to what happened on the latest conferences, especially the European Hematology Association that was in Amsterdam in June of 2019. So before we go ahead, I think I can have the control here. Yeah, that's fine. So we'll go for a rapid outline about multiple myeloma, just to be all on the same page, and then what are the questions or some of the main questions that we are asking these days, and then we go for the update and the results that were presented at this meeting. So multiple myeloma is a type of blood cancer. This is the myeloma cell, or the normal plasma cell in the body. So the plasma cell is a lymphocyte at the end of its differentiation. It is part of the immune system. It produces immunoglobulins to fight infection. So when this cell becomes abnormal, it proliferates outside the normal control. We have much more of these cells, and these cells are abnormal and similar, which we call clonal, and accordingly secrete the same type of protein. So we call it monoclonal protein, or protein coming from a similar clone, and the protein itself is similar in structure. So when we do protein electrophoresis, or separation of the plasma proteins in an electric field, we have what seems here like a spike or a big amount of a similar protein that migrate in the electric field at the same region. So we call it the M protein, or monoclonal protein, or myeloma protein. So this is a characteristic of the disease. And then with the increased proliferation of these cells we have the bone disease. These cells have affinity to settle in bones and to increase bone resorption, decrease bone formation. So we have these characteristic images that we see on the X-rays, and that protein itself can go precipitate in different organs or can be toxic to the kidneys. And with the resorption of bone, we have increased calcium in the blood. Lastly, when these cells proliferate and take too much space inside the bone marrow, so we have symptoms of bone marrow insufficiency like anemia or peripheral cytopenias. These are the main characteristics of the disease, and these are the reason why we treat to prevent damage to other organs, bone, kidneys, and so on. So the disease is not new, just the history of the multiple myeloma. We have even in mummies images that seems to be of a metastatic cancer that could be similar to multiple myeloma. But in recent history, the first case described of multiple myeloma goes back to the mid-19th century, and since then, over more than a century, the disease was well characterized, or more or less characterized as we know it today. So it took time to know what is the proteinuria that was characteristic for these patients, and we defined what is a plasma cell. We then came to be able to do bone marrow examination, protein electrophoresis, and so on. And this brings us to the 1960s. After that, the treatment itself, we know the disease is sensitive to radiation when it is localized. However, when it is disseminated, like most cases, we need systemic treatment. The first that showed activity are alkylating agents like the melphalan. We still use it until today, and the corticosteroids, the cortisone, the prednisone, the dexamethasone, and these work on the malignant plasma cells as if it is a specific agent or a chemotherapy. So since the 1960s to now, several trials tried to improve over the association of melphalan and prednisone, but were not successful. And we came back to the 1990s where we documented or proved that the higher dose of chemotherapy, the more sustained the response. We cannot go with chemotherapy, with the dose of chemotherapy indefinitely, otherwise we are toxic. We have to limit ourselves to the toxicity to the bone marrow. Came the principle of autologous bone marrow transplantation, where we take part of the bone marrow cells. So it's outside the body. We give the chemotherapy, and then a day later or more, we re-inject these cells. So we shield part of the bone marrow from the chemotherapy, and with that, the results or the response of the myeloma became more durable, and came also from the late 1990s the newer agents, including the thalidomide and next generation of immune modulators like lenalidomide, pomalidomide, and the proteasome inhibitors, the bortezomib, and newer type of proteasome inhibitors. With that, the situation nowadays that we have many classes of medications that work on multiple myeloma. We usually associate an agent from each class of this medication. The corticosteroids, again, corticosteroids alone are active medication for myeloma. The alkylating agent like melphalan, cyclophosphamide, and others. The immune modulator, the thalidomide, lenalidomide, pomalidomide, and the proteasome inhibitors, bortezomib, carfilzomib, ixazomib, and very recently, the monoclonal antibodies, very commonly used, at least in Canada, the anti-CD38, the daratumumab, and probably in the near future, another anti-CD38 called isatuximab. With that, that's how the management of multiple myeloma is happening, at least until early 2019. And with that came the question how to do better. So multiple myeloma is often preceded by a pre-malignant condition like the monoclonal gammopathy of unknown significance, or multiple myeloma with no organ damage, which we call asymptomatic or smoldering myeloma. With few exceptions in the smoldering myeloma, these patients we follow. We don't know who is going to progress to multiple myeloma and when yet, so it is a matter of very active research to try to select patients that we may treat before they have manifestation of organ damage. The initial workup when someone presents with multiple myeloma, what type of imaging? Should we do X-ray? Should we do CT scan? Should we do PET scan? Should we do an MRI? The standard is still in most places is the X-rays or the low-dose whole-body CT scan. The role of more sophisticated imaging is a matter of research. How to stratify patients with similar risk factors. This is important to give a prognosis to the patient, and also this is important for clinical trial to document the activity of a regimen over the other. And then the initial treatment for a patient with myeloma who needs a treatment, and then the response evaluation. So we have a standardized way to evaluate a response, so we can report things in a similar way. And then still important for eligible patient to do high-dose chemotherapy with autologous stem cell transplantation, although the relative importance of the transplantation becomes less prominent with the improvement of the other treatments. And then post-transplantation or maintenance treatment, as all these treatments so far for most patients are not yet curative, so there is a role to maintain some treatment to delay relapse or delay the need for another treatment, and then what to do when the disease comes back. So all of these points, that's how we manage the patient, and also at each item there are questions, how can we do better? There are for sure other items like the supportive care, bone consolidation therapy, how to protect the kidneys promptly. There are issues of quality of life, survivorship, impact of the disease on the patient, on the family, and the cost analysis and all of that. So we probably won't have the time to go through all of that, but we'll talk about how we treat myeloma today. So we still distinguish those who are fit for high-dose chemotherapy and autologous stem cell transplantation, or probably too frail to do so. For those who are young and fit, we usually give the association of cyclophosphamide, an alkylator, bortezomib, a proteasome inhibitor, and dexamethasone, a corticosteroid. That's how we do in Canada, where there are small variation all over the world. For those who are not transplant eligible, many centers in Canada still give CyBorD for 6 to 9 cycles. Some provinces or some centers give lenalidomide and dexamethasone. It's an oral treatment. However, it's a treatment that we give and continue until progression. Now, what happens when the disease comes back? We go back to the list of agents we have, according to the treatment given first line. How effective was it? How tolerated was it, and if it was well tolerated and effective, we may repeat it. If not, we go to a different class of agent or a combination that include a different class of agents with different mechanism of resistance, and hopefully, and so on, we alternate. Unfortunately, with time, we ran out of options. That's why we will end up talking about the newer medication we have in development. So, so far, that was the background. Now, what's interesting recently for transplant-eligible patients, so this is a trial was reported by two French authors, Dr. Philippe Moreau from France, and so about the association of a monoclonal antibody, the daratumumab, to their standard first line, which is bortezomib, thalidomide, and dexamethasone. So this trial reported also showing the impact of this addition of daratumumab on the minimal residual disease analysis in the two groups was also reported by another French author, Dr. Hervé Avelloiseau. And that's the design of the trial. So patients who are transplant eligible, performance status relatively good, and they have an induction, either the standard here in green, Velcade, thalidomide, and dexamethasone, or more or less the same with the addition of the daratumumab. And then we assess response after the few cycles of induction, and then we go for stem cell collection, transplantation, and then they give 2 cycles of consolidation with the same treatment given before transplant, and then they randomize should we observe or give daratumumab maintenance treatment. And with that, we see that the response is much better for those who have the daratumumab, with about 39% of people achieving complete response and 93% overall response rate, compared to 90% overall response rate and only 26% complete remission. So these results are quite significant. We look at the depth of response as an early indirect marker to how durable the response will be. So here, when we look at the progression-free survival at 18 months, we see that a significant proportion of patients, much higher proportion of patients with the daratumumab arm are still not in progression compared to those who did not have daratumumab first line. So the hazard ratio is less than half of progressing when we receive the daratumumab. So these results are very important. Now to the other aspect of what was reported so far from this trial, the minimal residual disease negativity with a certain cutoff. So it is much better when we add the daratumumab at different time point, at the post-induction and post-transplant and the consolidation. So very interesting results. We probably will see daratumumab as part of the first line soon. Here in Canada, we don't use the VTD as first induction. We use the CyberD, but probably this indirect data will support that we add the daratumumab to our induction. So I will go ahead. This is the author's conclusion that it is better, and we also agree with that as Canadian institutions. So this is the first interesting two reports from this meeting. Now, for those who are not transplant eligible, either they are frail or not young enough to feel that high-dose chemotherapy and transplantation is safe. So we have a trial called the MAIA trial that compared giving lenalidomide or Revlimid and dexamethasone compared to DARA, daratumumab plus LEN-Dex. Now, this report is about the safety and efficacy in transplant non-eligible patients. This is the design of the trial. Here we analyze the patients who are less than 75 years of age or above 75 years of age. And either we are younger or older than 75 years of age, we still benefit from adding the daratumumab to the lenalidomide and dexamethasone. Again, very robust, very interesting data that, again, here that's the details of the response. For sake of time, we'll have to go faster than that. And this is the minimal residual disease assessment in both group, younger or not younger than 75 years of age, and the percentage of people who achieve minimal residual disease is much higher in the daratumumab arm. And more or less the toxicity is very acceptable. There is a little bit higher number of patients having pneumonia and a little bit higher number of people having neutropenia or cytopenia, but the results are manageable, and this also may be an interesting line of treatment to come in the months or in the near future. So that's for our first line. I will go beyond the first line here. We said that our standard of care over the last years is to give an induction, transplantation, and maintenance treatment. The most common maintenance used worldwide and probably for sure in Canada is the maintenance lenalidomide. Now, lenalidomide was also a second line for those who have bortezomib-based induction. This data comes from our colleague, Dr. Chris Venner from Edmonton, from the Myeloma Canada Research Network National Database. So it's all Canadian data, and the database took years to come active, so this is one of the early results. So that's about the database. We have probably the data from more than 6,000 Canadian patients already available for analysis, and other centers are joining, and these are the centers who participate to the database so far. And the question that we wanted to ask are those patients who have maintenance lenalidomide, when later on we treat them with lenalidomide-based second-line treatment, do we lose among the efficacy, and overall, do they do better or not? And the answer for that comes from, so these are the characteristics of our patient, but what comes from this data is that it is better to continue to give maintenance lenalidomide after transplantation, and this still beneficial even if we consider a second-line lenalidomide-based treatment. So I will go fast just for sake of time and show the results that we have, those who have LEN maintenance after the transplantation, those who did not, and we still have a benefit if we give lenalidomide-based second-line treatment. And so this supports that we continue with our ongoing practice, but the data answered a question, and we are happy to answer it, and we are comfortable to answer it. So what else for relapsed myeloma or refractory myeloma? Carfilzomib is a more active proteasome inhibitor. which is in use and approved in Canada in most provinces and institutions. But until recently, carfilzomib was given 2 times a week, 3 weeks over 4, which means that the patient has to come for this intravenous medication 6 times to have the medication to the nearest institution. We don't include in this 6 times that they need to come for blood work and maybe need to come to see the doctor for assessment and so. So it was not very comfortable, and not everybody will have enough support to come to the institution 6 times. And it was lots of time wasted coming and spent in the chemo room. So this having carfilzomib given once weekly was a significant improvement, at least from the quality of life aspect of our patients. So this trial showed that once weekly is probably as good as twice weekly, and this is in frail or intermediate patients. So that's the design of the trial, to give once weekly or twice weekly. And here, I just reduce the presentation as much as I can here to see that's the benefit in fit patient or intermediate or less fit patient. So at least it is not inferior. We don't want to prove that it is superior, but at least it is non-inferior. So at least in my province here in Manitoba, we would accept to give only once weekly carfilzomib from over the last few months and probably in the future. So interesting results. Again, another important information that we were waiting for. As we said, daratumumab is important in first line for transplant eligible, non-transplant eligible. It is already approved in second line in most Canadian provinces. However, it is a parenteral medication. It is given over long hours. Our patient will have to stay for long hours to have the treatment in the treatment room. And it is given once weekly for 8 weeks and then once every other week for another 8 doses. So for the first few months, they are spending lots of time in the treatment room. There is new formulation, a subcutaneous formulation. It is undergoing clinical trial to prove that it is at least as effective. So this is the first report coming from an author from Spain about a non-inferiority phase 3 trial comparing subcutaneous versus intravenous daratumumab administration in relapsed and refractory myeloma. I would expect that if proven with the results that I will show now, that we will be ready to accept the subcutaneous administration. So this is the design of the trial, a standard design, and this is the time spent to give the medication. When it's given intravenously, the first dose can be given of up to 7 hours, can take longer if there is a reaction or so. The second one, the subcutaneous one, is just given over 5 minutes at any administration. The subsequent cycle for those who did not have infusion-related reaction can be shortened to about 3.5 or 4 hours, but we see that we save a lot from the patient time and also from the hospital resources to administer a subcutaneous administration. And with that, we see that pharmacokinetic analysis, it seems non-inferior to give the daratumumab subcutaneously, and response-wise, we have a trend to say that the subcutaneous is better, but the aim of the trial is to say it is not inferior, and I think the trial proved that. So these are very important data for us, an important progression to say that the subcutaneous formulation could be substituted to the intravenous one, at least in relapsed refractory, and hopefully this will become a standard of practice probably in a year or so from now. again. So that's, we are very interested with this trial, and still this formulation should go through the approval process in Canada, and hopefully will happen in the near future. Now, we have to go probably faster. So pomalidomide is a standard or an accepted treatment as a third line. We know bortezomib and dexamethasone alone, the response is about 4.5 months. We try to give it in combination. Some jurisdictions have bortezomib retreatment approved. So this trial tried to show what is the response to give the combination of pomalidomide, bortezomib, and low-dose dexamethasone in relapsed patients after lenalidomide. So that's again the design of the trial: bortezomib, Velcade, Dex versus Velcade, and dexamethasone. Here the Velcade is given a little bit different from how we give in Canada, day 1, 4, 8, and 11. We used to give it day 1, 8, 15, and 22 of a 28-day cycle. So a little bit different, and we also tend to give the pomalidomide at a different schedule than what's described in this trial, but still important data. And we see here that the combination is better than giving Velcade Dex alone, and it's almost double the response time. So even the difference here is much longer than that what we would expect from POM and Dex as a subsequent line of treatment. So very interesting data that we should take in consideration when we manage our patient in third line and beyond. So I will go again faster here and go to the new agents we have for relapsed and refractory multiple myeloma. One of the agents that grab lots of attention is a newer anti-CD38 antibody, so a little bit similar to daratumumab, probably, well, some presume it might be with different activity or more active. So we have a result here to say pomalidomide and dexamethasone versus pomalidomide and dexamethasone with this new monoclonal antibody, and the results, so that's the design of the trial, and the results are significantly better. So compared to 6.4 months or 6.5 months, we have 11.5 months. That is significant, and in this heavily pretreated patients, those who have 2 or 3 lines of therapy have probably better outcome than those who have more than 3 lines of therapy. So very interesting data. We'll see what would happen when we try to have this isatuximab in earlier lines of treatment. So stay tuned, more data to come, and other trials are ongoing. So again, we see not an overall response rate, much higher response rate when we add the isatuximab, and those who have complete response or very good partial response, which means deeper responses, are also more compared to when we don't give the monoclonal antibody. And the time to next treatment, also we are saying the same thing in different way. The time to next treatment is much longer, with something like 9 months in the POM-Dex, compared to not reached at the time the trial was reported when the monoclonal antibody was added. So that were the conclusions. And another interesting molecule that we probably will hear about it more in the coming months which a new cell mod or a newer version of lenalidomide, pomalidomide, is called Iberdomide. So a very early phase, Iberdomide and dexamethasone, the results were also interesting. We are looking for the results of ongoing trial with Iberdomide+Dex and other agents, Iberdomide+Dex, bortezomib, Iberdomide+Dex, and daratumumab. We know that these trials are ongoing. The trial with Iberdomide+Dex so far are quite interesting. So we'll see the results hopefully in the coming few months with the more elaborate combinations. That's probably, I will stop here. Just very rapid word about other molecules that many of the Canadian patients know about it. The results from selinexor, from melphalufen. Trials are ongoing. We couldn't include it today for the sake of time. And for sure, the immune therapies, the CAR-T therapy is still ongoing, still interesting. We need more data about the safety before this comes to clinical practice, and the technology is getting better. Also, the bispecific antibodies that attach to a protein on the myeloma cell and a protein in the immune, on the T cells. This also, we see interesting data, and we still need more data about the safety before this comes to early phase clinical practice, well, let's say early line of treatment or to larger clinical trials. So that's all for me today. I'm happy to receive any questions.
Thank you, Dr. Koch, for excellent presentation. Lots of information. So we do have, we have a few questions that have already been submitted. So for those who have not yet submitted questions, there's a little tab on your GoToWebinar screen where you can click on question, type in the question, click send, and I will receive the question. So the first question has to do with transplant and CyBorD. As you know, in Canada, CyBorD is used as induction treatment for transplant eligible patients. And now with the new data and with the European approach of DARA, LEN, bortezomib, and Dex, do you think that Canada would adopt that approach, or would it adopt an approach of daratumumab plus CyBorD?
Well, I cannot speak for other centers, but I think the common opinion is that we might adopt daratumumab CyBorD. The issue here is that thalidomide is more present in other countries. It's much less expensive than lenalidomide. In North America, we prefer CyBorD or VRD, which means bortezomib, lenalidomide, and dexamethasone in many American centers. We have some data so far to suggest that DARA with CyBorD is probably a good option, and we would probably be more tempted to consider DARA CyBorD or to prefer DARA CyBorD. But this probably will come in still have few months, and this is a topic that we discuss often in our meetings too.
Okay, thank you. The next question here is about quality of life, and on someone who you know, if a treatment regimen such as lenalidomide and dexamethasone is causing poor quality of life, such as like a lot of diarrhea is the example given here, are there any suggestions or what would be clinically done in a case like that to improve the quality of life?
Well, it depends what side effects and why it is not tolerable. So diarrhea could be a side effect of lenalidomide. This is known, and if other causes are ruled out, a trial of a specific agent like Lodalis or so can be very effective managing the diarrhea. So whoever had the side effect needs to report it promptly to his clinician. When we inform our patients about side effects, it's not just to tell them, okay, these are the side effects, you have to live with it. We tell them about the side effects, so if they have it, they associate it to the treatment and report it to us, because often we have tools to mitigate these side effects. So we want them just to know that the lenalidomide may cause diarrhea. So if it happens, we want to know, because we may be able to do something to fix that. Other side effects, probably more difficult, like fatigue, thrombocytopenia, intolerance to dexamethasone or so, all of that need to be reported to the clinical team to make sure all measures to mitigate these side effects are in place before saying that we have to change line of treatment for that. So again, we have more options of treatment. However, it is not an infinite number of options. So we have to be sure with each treatment line that we are doing the best, or we're taking the best of each treatment line before deciding otherwise. So there is need for a specific discussion with the treating clinician in this regard.
Thank you. The next question has to do with transplant eligibility in someone with renal insufficiency or renal injury. This person is asking if there's any research that's taking place that with regards to allowing someone with renal injury to go through a stem cell transplant.
Yes, patient with renal insufficiency can be considered for renal transplantation. So again, this is not an absolute contraindication. It depends on the other comorbidities, on was the renal transplant only due to myeloma, or he has other comorbidities, how is his general condition, and all of that. So again, this needs a specific discussion, but it is not absolute here.
Okay, thank you. One person is asking, how does a patient get involved in a clinical trial, or participate in a clinical trial? What are the steps?
Well, usually the institution where he is followed or treated have to activate a clinical trial. A clinical trial has to go through regulatory steps, including research ethics board review, to make sure that the patient is protected when he or she participates to a clinical trial. So the clinical trial should be either active in the center where the patient is treated, or the patient may be able to go to another institution where a clinical trial is active. And the treating team is often aware what is active in their center, or in the case of the myeloma team, is very, we communicate relatively very well between institutions. So we may be aware of a clinical trial that is open in another institution, and if a patient can benefit from being in this clinical trial, we may suggest him to go to another institution. In our center, we often send or suggest people to go not only to other provinces, but to other, let's say, south of the border for another clinical trial open in other institution when we feel that the treatment option there warrant this.
Okay, great.
So the first step is to communicate with the treating physician what are the clinical trials, or for sure to communicate with the patient group. You guys have the clinical trial portal and all of that.
Okay, great, thank you. The next question, I have quite a few questions here, so I'm just going to go through the next one. In someone who's transplant eligible, are they able to get daratumumab?
Well, the data is relatively new, so to be transplant eligible and have daratumumab prior to transplantation, so far in Canada, it is not yet approved. Special access or access via special insurance, or if there will be in the future some sort of compassionate access or so, it's something that the person can discuss with the treating physician. However, it is not yet, as of today, approved in Canada, but might be in the near future.
Okay, thank you. Okay, I'm just filtering through these questions to make sure I ask you a good one. Okay, so I can't ask that. So someone is asking, for you to elaborate on CAR T cell therapy.
Well, CAR T therapy, or chimeric antigen receptor T cells, T cells are part of the immune system, so we can orient them to attack the myeloma cells. So this type of therapy showed relatively interesting results in other hematological cancers. It is still experimental in multiple myeloma. And then experimental means that we are still evaluating the efficacy, the durability of response, and the safety. So it is not over-the-shelf medication that we can keep on the pharmacy. We have to send the patient for assessment if we consider that in a clinical trial, and then they take his own cells and manipulate it, return the cells or so. So it is still experimental, and I expect it will remain experimental for for at least the near future. The technology is improving fast, though, so we probably have the impression we are having more reliable product, safer product, and so. So far, we collaborate with other institutions to send our patient we feel eligible to participate to this in clinical trials, but we expect that it will remain an experimental measure for at least the coming year or so, if not longer than that.
Okay, thank you. The next question has to do with stem cell transplant and maintenance therapy. So there's two questions in one here. So the first one is, how long after a stem cell transplant can maintenance therapy be given? And the second question here is, what are the options for maintenance therapy? Is it just lenalidomide, or are there other options?
Well, thank you for that. So we start maintenance treatment around day 100 post-transplantation, more or less around that. That's how the trial were done, and that's how most institutions do, to allow for good reconstitution of the hematopoietic system before starting the maintenance treatment. Now, we do maintenance with lenalidomide. That's the most common here. Sometimes we consider maintenance with a proteasome inhibitor. We have some data to say, okay, patients with high-risk cytogenetics may benefit, again, more from maintenance with Velcade or proteasome inhibitor, or based on that. We have interesting data with oral proteasome inhibitor ixazomib as a maintenance, but these are not common, at least in Canada. Again, combination maintenance could be also an interesting option, but not a standard, at least not a standard in Canada and not a standard outside clinical trials. The data of maintenance monoclonal antibody in association with other could also be an interesting option in the near future. So maintenance is an area that may change in the coming 12 months or so. So again, stay tuned. But for now, most of our Canadian patients have maintenance lenalidomide.
Okay, thank you. So just going through more questions. Sorry for that. I'm just making sure I have a question here. Do you think? I guess a question which doesn't really have to do with the research, or like kind of does have to do with the research, is it's a simple question. I'm sure you hear it a lot, but someone is asking it. So do you think there will ever be a cure for myeloma?
Well, we hope so. The question, people were very conservative to call anything a cure. Historically, when the first patient with Hodgkin disease, we have the disease gone, and we thought they looked like everything is normal, the term complete remission came to our practice because we were very cautious to tell people, oh, you are cured. And the definition of a cure means that, like someone who had flu and now he's cured, he doesn't need to do more treatment, he doesn't need to do more blood tests, he just forget about it, it's in the past, it's cured. So I think for now, even we see patients who have durable complete responses or not, and we remain for years, more than 10 years, 14 years, 15 years, and we still follow these patients and they're still doing very well, never needed any treatment again. Again, these patients were very few in the past. We expect to see them more often. However, when we do a treatment for someone, even when everything goes back to normal, we check with more sophisticated tests for the minimal residual disease and it's still negative, we tell them, okay, you are in complete remission, we are still cautious not to tell them we are cured or you are cured, because at least we'll need to follow them up until we can have a good assessment how durable this response will remain. But hopefully in the future we'll see more durable responses and more long period without need for or without seeing the disease coming back. But maybe in a few years we'll talk about who should we de-escalate or not, but not for now yet. But I hope in the coming few years we'll be talking about that more than now.
Oh, fantastic, great. Thanks again. So the next question, I know you're very passionate about this topic, Dr. Ctrough. As a hematologist, when as a hematologist treating someone with myeloma, you know, do you stop at just treating the myeloma, or is it more of a holistic kind of approach where, you know, the side effects of the treatments are also treated, and so on and so forth? So what are the responsibilities of a hematologist when it comes to treating a myeloma?
Well, the treating physician or the treating team should always be aware that when we treat a disease that is not curable, let's say it's not a month of treatment and then we stop, the quality of life is of paramount importance. It's very important here. So we treat a chronic condition, the quality of life, well, the longer survival and the better quality of life are the goal of the treatment. So we cannot say to someone, okay, you have to accept this treatment and live with chronic bad diarrhea or chronic fatigue for the rest of your life. That will not be acceptable. So we need a longer duration of response and a better quality of life. Both go hand in hand. So from the start, and this all the aspect of survivorship, how often they should come to the hospital, how often they should come for a treatment, what is the time wasted for just to care for the disease, not only inside the hospital, but going to do a lab, coming back, going to have a treatment, coming back, going to see the doctor and waiting or not. All of these are aspects that should be taken in consideration in our team, and I'm sure in all other teams, are trying to have the patients as close to a normal quality of life and to reduce to the maximum the number of visits to the hospital as much as we can, but for sure there is room to improve that. And for sure we should be very prompt managing side effects because this impacts the quality of life for sure.
Okay, great. Another question, I guess we have time for maybe one or two more questions. So the next one will be about lenalidomide and as maintenance therapy again. Now, what are the long-term effects of lenalidomide as maintenance therapy, and can it lead to kidney or liver damage?
Well, the long-term side effects are often explained. We cannot explain it all, but most of our patients should, well, all of them should be informed of the side effects. Most of them will have written information regarding the medication and the potential side effects of the short, of the long, and the long term. So we cannot go through it all today. However, the dose of lenalidomide has to be adapted to the kidney function. That's one issue. And controlling the disease protect the kidneys, otherwise the disease itself can harm the kidneys. So that should also be taken in consideration. I'm sorry if that's probably not all the answers that for the question that was asked, but it would be very long to explain more than that.
Mm-hmm. Okay. Okay, so that's understandable for sure. So let's go to one last question, or if we could fit in an extra one, then we'll do that. But we'll see how long this one takes. Is there any research going on for people with high risk genetic markers such as P53, something like a mutation in myeloma that makes it a little bit more aggressive?
Yes, well, there's lots of research ongoing. First, to better quantify the prognostic value of any marker. Could be cytogenetics or not. So this is a very active field of research by many teams that we know about. Now, a specific treatment for a specific translocation, we have rare examples of that, but again, not in common practice. So for now, we treat these patients more or less in a similar way like others. One of the most important prognostic factors so far is the response to treatment. So for sure, we can have prognostic and predictive values. We take that in consideration to stratify patients in clinical trial, not to be biased toward or against the effectiveness of an agent. However, for a single patient, how can we use this information that's not exactly the same issue, and the quality of response and durability of response are probably the most important aspects here.
Okay, great, thank you. So, Dr. Cott, thank you very much again for an excellent presentation. I'm getting a lot of great feedback from the people on the line, and they're very appreciative of all the answers you're giving. I just wanted to remind everyone that this is being recorded. It will be on our YouTube channel. We'll probably upload it at some point tomorrow. So you could go back on YouTube and you can go in and check this webinar out. If you have trouble finding it, please don't hesitate to call us or to email us, and we'll help you find it. I know there's a lot of questions that I probably didn't get to answer, and some of them were some personal questions. So for those questions, please contact your treating physician. And if you'd like to talk at the office, please do not hesitate to call us. I'm at the office Monday to Friday. I'd be happy to take your call and answer any questions I could anytime. So again, thank you very much, Dr. Kotby, and have a wonderful night.
Thank you, and thanks for everybody who signed in. All the best to everybody. Bye-bye.
Bye-bye.